Okay, so let's start with some examples of large animal models of severe pneumonia. And the first who did something was Waldemar Johansson with baboons. And really, that work was important for our understanding of ventilator-associated pneumonia. And the model was of oleic acid. And the original thing there with that investigation is that they performed prolonged mechanical ventilation, at least 3 days, because it is very difficult to ventilate these animals for more 7 days for several reasons. The group Kolobov and Gianluigi Livaggi and Mauro Panigada performed studies in sheep, trying to see if the prone position versus semi-recumbent position prevented ventilator-associated pneumonia. That the problem of sheep that they regurgitate a lot, they are ruminants, and then they stopped, I think, doing this type of investigations in sheep. And you can see the details. I'm not going through that, but the studies were important to know that we cannot use these animals for the study ventilator-associated pneumonia. And the first to do using swines was Charles Marquet in Lille, that characterized of an animal model of ventilator-acquired pneumonia, female in position to allow secretions damage, and all these animals develop histologically proven pneumonia, and by endogenous flora of these animals, mainly Bacillus multocida and Streptococcus suis. And then we learned that model. We went to Argentina with Carlos Luna. This is our ICU pig. We performed this study in piglets, in the same race, the same type of weight, and in animals that were healthy, of course. This is the big difference compared to the real life. This is important. And this is one of the first studies that we performed. This study was done in Argentina. And then we set up a model of Staphylococcus aureus methicillin resistance that allowed to study us with that model more than several antibiotics against Staph aureus methicillin resistant. In that model, all the lots had histologically confirmed pneumonia, and we performed a challenge of Staph aureus methicillin resistance in each lobe, high burden of microbes, and the model was reproducible one, and these animals had pneumonia at 24 hours after the challenging them with Staph aureus methicillin resistance. Then we went, we thought that this model of the challenging was not the real life, and we performed, or we went to another model, in that case of Pseudomonas aeruginosa pneumonia, and instead of challenging the bronchi, we placed a concentration of bacteria in the oropharynx, which is, it seems, and trying to reproduce what happens in real life. And these animals were in anti-Trendelenburg position, mechanically ventilated up to 96 hours, and we challenged twice the oropharynx, but not the bronchi. And most of the animals developed pneumonia in that position, indicating that, well, this can mimic what happens in mechanically ventilated patients. So with this type of models, the challenge versus the oropharynx, then we studied several issues in pneumonia. Well, the advantages of big animals, long-term mechanically ventilated, is that we can do studies in 4 or 5 days. The animals have larger size and technical possibilities. We can study monolobar versus bilobar pneumonia or bilateral. The genetics is more proximate to humans, and we can reproduce the ICU conditions, and we can perform medical imaging. But the limitations obviously are high cost, reduced sample size. You cannot study a lot of animals. Usually we study 6 to 8 per group. they are healthy, or they were healthy animals without comorbidity. They have concomitant endogenous flora that is different compared to humans, and they were deeply sedated through the experiments. Well, the application of this model is multiple. Is what we did in the years after the development of the model. You can study several issues of the pathogen. You can study the host as well, and you can study, very importantly, therapies or methods of prevention. This is one of the studies that we have performed using ultraviolet light. This is not published yet, but in vivo and in vitro studies demonstrate that this light has antimicrobial activity against pathogens causing VAP. There were some positive signals in the COVID-19 critical patients, and then we wanted to perform a preventive study to prevent ventilator pneumonia in our animals with the mode of placing a challenge in the oropharynx. And we started with comparing the administration of ultraviolet light versus a sham technique. And then we measure the concentrations of bacteria in endotracheal aspirates, in VAL, and finally in the lungs. And we could see, we have to finalize this series, that the burden of the disease was lower in the light compared to the sham, in endotracheal aspirates, and in the BAL as well. This was measured at 12 hours after the application of ultraviolet light, and the same when we performed the necropsy of the animal, and we examined the lung. And you can see here the lung bacterial burden regarding Pseudomonas aeruginosa for comparing the light versus the sham. So that means nothing. Another type of studies that we performed have been in the field of nebulizing antibiotics in mechanically ventilated patients. You are very aware that the trials that had been published in using amikacin nebulized, in that case nebulizing amikacin, and then the Bayer trial were negative mainly. But despite, for example, in this trial, there are synergistic effects between amikacin and fosfomycin, and there is a reduced incidence of development of residence, we cannot find difference in the final histological results on the lung bacterial burden. But what we observed, which is important, and we have to think about that, but probably because that the trials were not totally negative, there was a decrease in the lung bacterial burden in the tracheal aspirates in that study from Kolev, comparing the nebulized group versus the placebo group. And in that case, we performed the study that was published 2 or 3 years ago. We nebulized amikacin and fosfomycin for severe Pseudomonas aeruginosa pneumonia in our model of pigs. And what we could find is that the burden of the Pseudomonas in lung tissue was lower when we combine amikacin fosfomycin plus IV meropenem, but especially this was observed in tracheal secretions, indicating probably that nebulized antibiotics, what I can do is not to modify the lung bacterium burden of the lung, and instead they can decrease the lung this can be important for avoid relapses and second infections, in that case with Pseudomonas aeruginosa pneumonia. This is a trial that we performed in our model as well. Was published in Critical Care Medicine. The first author was Anat Motos, and we compare controls, pig receiving IV meropenem, and then meropenem amikacin with the system that Bayer developed, or the Bayer used, was the Nectar system. And then look at what is in tracheal secretions, very important. Within time, they maintained low levels of Pseudomonas aeruginosa, there were differences in the bronchoalveolar lavage, and importantly, is this something that we need from before, is that in patients receiving aerosolized antibiotics plus meropenem, there was less resistance of development of resistance of Pseudomonas aeruginosa, and by contrast, in the group of meropenem, there was a 30% appearance of resistance. During the study, animals were ventilated for 4 days. Well, let's move now to severe community-acquired pneumonia. You know perfectly what is and the burden of the disease. I'm not going to go to this slide through the details, but we published the following model. I think it's the first one in Streptococcus pneumonia, because Streptococcus pneumonia is important to be studied in animal models since it's the first microorganism in the community causing community-acquired pneumonia. And then we studied endogenous flora in 4 healthy pigs and in 10 additional pigs with intrabronchially instillation of Streptococcus pneumonia serotype 99, and characterized in that case that strain by resistance to penicillin, macrolides, and tetracycline. The pigs remained ventilated for 72 hours, and most of the lungs that were studied at necropsy, we found Streptococcus pneumonia in high concentration, bacteremia in 50% of the infected pigs. This is important, and pneumococcal pneumonia was confirmed in all infected pigs. So the model, I think, is important to study new strategies to treat strep pneumo, both with antibiotics and non-antibiotics. So this is our model, was published in Animal Lab, which is the best journal, best animal, the studies for animals is the best journal that exists. And I think that this model is open for discussion. You can see here the histological and the microbial findings. All the animals had pneumonia, and you can see here the bacterial burden regarding strep pneumo, but we could not eliminate all the pathogens that are from the oropharyngeal flora or the endogenous flora of the animals. And these pathogens were Bordetella bronchiseptica, Streptococcus suis, Streptococcus eos, and Staphylococcus as well. Importantly, I think this is very important, and I think Tobias Velte is and knows this probably well. We studied 2 of the drugs in that model of strep pneumo that we are using for treating strep pneumo, fluoxetine and ceftriaxone. And we observed, measuring the ELF concentration, that for ceftriaxone to achieve the best PK/PD parameters, we should use in that model almost the double or more than the double of the doses that we use in humans. So I think because ceftriaxone is a drug that has not been studied in depth, but it is in the standards of care for community-acquired pneumonia. Okay, in that model, and this is not published yet, in that model of STEM, we studied something that is now very burning, a burning issue, is if the administration of corticosteroids are doing something or not. And we compare controls with animals treated with ceftriaxone plus levofloxacin, or ceftriaxone plus azithromycin, or ceftriaxone plus levofloxacin plus methylprednisolone, or ceftriaxone plus azithromycin plus methylprednisolone 0.5 milligrams per kilo of the animal. And for the total of the experiments took 72 hours mechanically ventilated. And you can see here that for the lung tissue Streptococcus pneumonia burden, we found the lower levels with the combination of ceftriaxone, azithromycin, and methylprednisolone. We could not find strep pneumo in any of the samples of these animals treated with that triple combination. And this fits with the recent findings of recent clinical studies about corticosteroids. Something is a very burning issue here. Well, finally, and this is the the last model that we have, hopefully is going to be published, is the model of ARDS of pneumonia. ARDS is, or community-acquired pneumonia, is one of the most important and frequent causes of ARDS. And in an animal that we challenge with Pseudomonas aeruginosa, plus later on injurious ventilation, using high grades of respiratory rate, adjusting the PEEP, and with this inspiratory-expiratory ratio, so very injurious ventilation that was applied for 3 hours and up to 28 plus minus 3 hours until moderate severe ARDS gasometrically or clinically appear. And in that model, you can see that we divided the animals in pneumonia with villi and pneumonia without villi. So a group of animals only with the Pseudomonas aeruginosa challenge and Pseudomonas aeruginosa plus villi. And you can see here that the only real elements of distress appear when we applied the combination of pneumonia without villi. And here we have the extravascular lung water as well, comparing the two groups, the wet to dry ratio and the histological score. So we think that this is one of the first models in animals ventilated for 4 days and which could reproduce, or we could reproduce an ARDS. Of course, that this is not the same that would happen in humans, but can serve for study treatments and interventions. In conclusion, I think that the large animal models are important to elucidate the pathogenesis of lung infections, to characterize pathogen virulence factors, innate and adaptive immune response, and to test the efficacy and safety of novel therapies, preventive strategies, and new devices and mechanical ventilation strategies. But of course, you have to consider the features of the animal model, the physiological and anatomical differences with humans. I personally think that this could save a lot of money to the industries studying treatments, antibiotic, non-antibiotic, and strategies in this type of animals before moving to large randomized clinical trials. Thank you. And I want to thank my group, especially Jean-Luigi Livasi that now is in Brisbane. I want to thank to Anna Motos, who took care of the animal lab after Jean-Luigi Livasi and the group, and especially as well Laia Fernandez that are with ongoing research now. Thank you very much.
Very good, very good. Okay. Tony's presentation is open for comments, discussions. Yes.
Hi, Tony. This is Charles. How you doing?
Hi, Charles.
Yeah, nice, interesting model. I'm just curious, with these pig models with infection, is there a way to treat them and then extubate them? Are these terminal experiments? I'm just thinking about like when they resolve their pneumonia, how can you follow them sort of non-invasively or see how they're doing? Or re-intubate them or do a bronchoscopy later, you know, so.
No, this is feasible, of course. We can treat the animals. We can, in fact, indeed, we are preparing studies using that strategy, treating the animals, extubating them, and then waiting for 2 or 3 weeks, and then to re-study the animals again.
Cool.
And I think this could be good, for example, for the cardiovascular complications of pneumonia.
Right.
But it is feasible. It's more work, but it's feasible.
Thank you.
Any other comments? Tony, you alluded to the normal flora. Then we are trying to study the microbiome of the pigs.
Well, normal flora, the problem of the normal flora is that for each experiment, you have to find the right, or to administer the right antibiotic prophylaxis. Usually we use ceftriaxone and then you get rid of the normal flora. And then for the strep pneumo, we should think very carefully about that, because then KEF reaction is active against Streptococcus pneumonia. We now are going to study the microbiome of these pigs, but I don't know how it can extrapolable to humans. I don't know if this is going to be very useful. We will see the changes, but these are not going to be the same than in humans.
Yes.
So Tony, this is Rich.
Hello, hi, Rich.
So as I understand, the problem with your strep suis and some of these other parts of the microbiome is that if you don't suppress them, they develop a pneumonia with that microbe. Is that correct?
Well, if you don't suppress them, that is easy in the models of Pseudomonas and Staph aureus methicillin resistant. You find in lower levels these microbes in the lungs, as I showed. This is the case of the model of strep pneumo. I don't know what is the pathogenicity of finding this endogenous flora.
Yeah. So my question is, if it's truly endogenous flora, if it's truly the normal lung microbiome, then it would be interesting to not suppress it and see if you can induce MRSA or Pseudomonas pneumonia when you have a normal flora. In some ways, you're setting up an artificial situation, which, frankly, most of our intubated patients already have that situation of getting prior antibiotics. But, it would be interesting to know if this normal flora is actually preventing Pseudomonas and MRSA. I mean, I'm sure pigs are exposed to Pseudomonas all the time, and they don't get Pseudomonas pneumonia that we know of.
The problem, if we don't suppress that flora, the endogenous one, it is difficult to reproduce the model, because the endogenous flora predominates over Pseudomonas of FMRSA. We can do that, we can study, but we studied that. And then if you don't give to the animals prophylactic antibiotics, the endogenous flora predominates over Pseudomonas or MRSA.
Yeah, that's exactly my point. So you're not actually giving prophylaxis, you're actually inducing a pneumonia by your antibiotics.
Yes, you're right. It's some type of artificial situation, but I think it's the best way that we can do that. Otherwise, it's very difficult.
I'm not disagreeing. I'm saying that's what you have to do to get a Pseudomonas pneumonia. Just like in humans, we don't get Pseudomonas pneumonia until we get antibiotics. And it's the normal flora that
you're right.
That
you're right. In some ways, the same. Yeah.
Oh, yes. Is the idea that antibiotics predispose to pneumonia?
Of course, yes, no doubt.
Tony, this is Martin Litzner. Thank you for your talk. And first of all, congratulations that Barca won the La Liga.
Thank you very much. It's the first one in more than 4 years. Thank you.
Okay, so along the same line, I'm wondering, what is the reason for the outgrowth of the bacteria that are normally not growing in the lungs of these animals? And could it be that this is the direct or indirect effect of mechanical ventilation? I'll elucidate a little bit on that later, but I'm wondering what your ideas about that are.
About that, say it again, please. So you want to know what is the role of endogenous flora plus mechanical ventilation?
No, what is the reason for the flora to show this outgrowth that you normally do not see in the pigs, but you see it under mechanical ventilation? So is it really only that you need antibiotics to see that, or could it also be that there's a direct effect of the positive pressure mechanical ventilation on epithelial surface and so on?
I am sure that there is an additional effect of the injury caused by mechanical ventilation, plus the challenge, of course. Of course, but interestingly, in the study of Charles Hugo Marquette, the first one, all the animals develop pneumonia bacterial flora, all the animals, without any challenge. So in some way, I am saying that probably many patients intubated develop some kind of BAP or VAT, but it's not clinically relevant, or they are under antibiotic treatment. But it's very easy under the two injuries. So in humans, continuous aspiration of microaspiration plus mechanical ventilation. This is a tremendous injury to help ventilator-associated pneumonia occurs.
Yes.
Hello, Antoni Torres here.
Hello,
So
Tobias.
also, I'm very happy Barcelona made it. So
Thank you.
and I know this causes a smile on your face. So
Yes, a lot. I'm very happy.
So my question is, so these are young pigs, so they are not in any way comorbid. So from Rosario, we learned that comorbidity is one of the major mortality drivers, either short-term and long-term. Is there any chance, and I know this is really difficult, but is there any chance to modify the swines to be more like an elderly patient?
This is not easy to do. It's feasible. Again, we can do interventions in the patients and then extubate them, and to study after several weeks is what we can do. So it is not easy to induce a cardiovascular direct injury, but I think it's feasible, and it's something that can be important.
Rick said to choose more obese swines, so maybe this is
perhaps.
One question regarding your data, Tony. I think that you show when you give in your pneumococcal pneumonia pig, when you give antibiotics plus steroids, you have a decreased number of streptococcal pneumonia. You almost don't find the streptococcal pneumonia in the tissue.
Exactly.
Because in my mind, when I thought of you're going to give steroids, and then the steroids, anti-inflammatory effect, and you're going to have better outcomes, but you're not going to alter the number of bacteria because the steroid will be dealing with the inflammation. Why do you think that giving steroids, it's almost like giving steroids improve the immunity to kill more pneumococcus? Why is that in the steroid group, you don't find pneumococcus?
Well, I think that this was suggested by Umberto Meduri in an in vitro study that decreasing inflammation reduces the growth of bacteria. So less inflammation, less growth of bacteria, less growth of bacteria. The exact reason, I don't know the exact reason for that, but the inflammation predisposes to bacteria to appear in more concentration, in higher concentration.
Yeah, I remember what this story, but again, it's difficult for me. I always consider that you block the, yes.
Hello? I cannot hear you.
You hear me?
Okay, yes, yeah, I can hear you now. Okay,
You remember that those that received corticosteroids had lower level of bacterial count than those that did not receive corticosteroids. You remember that? In
yes.
Well, that happened also
Is
with
that you?
No, this
with
is, no,
Pseudomonas.
and this is why I asked, because I'm aware of the data, but the storyline usually is with the steroids, you block the, innate immunity, you have less white blood cells, less blah, blah, and the question was, you may get overgrowth of bacteria as one of the considerations. But I remember your data, now he showed with pneumococcus, with Pseudomonas, we give steroids and we decrease bacteria. Meaning we block inflammation, or we, in theory, block the neutrophil.
Exactly.
We have less netosis and everything. I just wanted to see what would be the pathogenesis to explain. It's almost like the immune system is working better when there's less inflammation, or at least the innate immune system.
I think this is one of the possibilities.
Any consideration? Yes.
No. This is, yeah, I agree with Julio. This is one of the possibilities. But what is the rationale to give steroids in pneumonia? Because now it seems that pneumonia can be only, it seems, after the Deccan study, that the effect is in patients with shock. But I always, from the very beginning, tried to reduce inflammation with steroids.
Yeah.
And I went to community-acquired pneumonia with a high inflammatory phenotype.
Yeah, there's another question. No. Then yes, trying to measure neutrophil activity in patients with in pigs with steroids and without steroids, to see if the steroids somehow improve killing activity of some of the neutrophils or other
Okay.
cells in
This is-
bronchoalveolar lavage.
This is a good suggestion.
No.
And doing a dose response study along with that.
Yeah, yes, a dose response study, yes. And also it's going to be a question on.
No, we have,
Yeah, what is steroids? Yes, well, it's going to be,
No,
to be
a
continued.
couple
We're
of
going
things.
to- Yeah. Any other general
We
comment?
will do these studies.
Okay. Well, Tony,
Okay,
thank you very
okay,
much. Yes,
Just a last words.
yes,
The model is, our models are open for collaborations. Okay.
perfect. Perfect. Thank you,
So
thank you very much.
thank you again for inviting me.
Thank you.
Bye. Bye bye.
Bye.
Take care.